भाई साहब 258 हो गए, चालू कर दो। हाँ
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on 1st and 3rd Friday of every month from 3 p.m. onwards. The NAMS-AIIMS PGIMER CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medico CME is to help them to be more proficient in their profession. Each session will covers 1 or 2 topics followed by questions and answers. Thank you for your kind support.
Good afternoon, everyone. So this time we are with another session and very interesting session in the series of oral and dental health. So this time the topic is restoration and rehabilitation of teeth with endodontics and modern restorative techniques. So earlier we all used to know that we all used to witness that once there were caries or once the teeth has uh, issues. So the most common uh, techniques were like just extraction of that particular tooth. So and since the natural tooth, once the kind of strength that the natural tooth have, uh, it we can't compare it with the artificial one. So restoration and rehabilitation of teeth is extremely important in today's era. And today with us we have very eminent speaker, Dr. Mitra and Hegde ma'am. So, without wasting much time, I would like to request Professor Umesh Kapil sir for the welcome address. And sir is the Secretary of National Academy of Medical Sciences. Over to you, sir.
Thank you very much, Dr. Jaswant. Dr. Jaswant is assistant professor at All India Institute of Medical Sciences in psychiatry. He has been always helpful to us in organization and conduct of Navigate CME program almost last 3 years. I would like to welcome, first of all, Professor Hegde, who has very kindly consented to deliver this CME session. This is a very important area. In fact, endodontics is becoming a very important specialty or super specialty amongst the dental sciences. And restoration is something which was not never heard of 40 years back. But now we have at least 7 super specialties in the field of dental sciences, and endodontics is one of them. My special welcome to all the participants who have very kindly agreed and joined this particular session. I'm sure that all of you are going to enjoy with the wisdom of Dr. Hegde. She has 485 publications. It's unimaginable. But she has been an outstanding academician. The Navigate program was essentially started. It's an online program which is being conducted on first and third Friday of the month. And we have about, it's an online program. It's being virtually available to everyone who wants to join it. It's also available on the YouTube. All the PowerPoint presentation and the live telecast is also being made available on the NAMS virtual library that is maintained on the NAMS website. The whole purpose is essentially that these are the common problems which are being faced by young faculty members, postgraduates of all the specialties. It's not restricted to the dental sciences, because if there is a caries, if there is an issue related to endodontics, it's a patient comes to every doctor. And what we are planning, what we have done is essentially to have this online program and to get the most eminent scientists working in this area. And we request them to share their wisdom, share their knowledge, so that everybody can be benefited by their wisdom. We are most grateful to Dr. O.P. Kharbanda, who has been very kindly consented to be coordinator of this series of lectures on oral health and dental sciences. Sir, we are really grateful to you for organizing and taking and everything to coordinate these sessions. With these few words, I would like to stop over here, and over to you, Dr. Jaswant.
Thank you, sir. Thank you for the welcome address. So now I would like to request for the message from Professor Digambar Behra. Sir is the president of National Academy of Medical Sciences. A message for all the participants from the president.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the norms. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you for the message. Now I request our technical team headed by Sri Raviji. So for the message from Professor M. Srinivas, sir is the director of All India Institute of Medical Sciences, New Delhi.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you for the message. Now it's time to welcome and convey special regard for the chief coordinator of the series, Professor O.P. Kharbanda sir. Sir is currently director at Delhi Cleft Care Center, and sir has formerly served at All India Institute of Medical Sciences as the chief of Center for Dental Education and Research, also chief for the CMET. Sir is also Professor Emeritus and Council member at National Academy of Medical Sciences. So I would like to request Sir for his remark on the current topic which is being presented today. So over to you, Sir.
Thank you. Thank you, National Academy, Dr. Kapil, and the President for this opportunity to have a series on oral health and dental diseases, which has happened for the first time. The National Academy has been in existence for about 6 decades now. With respect to today's topic, it is a huge subject. The conservation of teeth, materials, and principles, including endodontic, is a full subject which is taught for 4 years in the dentistry, starting from year 1 in terms of on the bench and then in the mouth, and of course it ends up to post-graduation. So I think Dr. Mitra would have a very tough job in condensing everything into 1 hour, 1.5 hours, and present it in a simplified way to give us how the things are changing and how the things will change in near future. We started with metals and now we have non-metallic restorations. And you will be amazed to know that once Dr. Bocon, who is known for bonding, visited a paint factory and he found that on the metal rods, the painter were etching it with acid and then applying the paint. And when he asked him, he said, I want to bond the paint with the metal rod. And that triggered the idea in his mind to replace metals with synthetic material into the teeth. So now, particularly with Minamata Convention in place, we have to phase out silver amalgam from the oral cavity. We are replacing all these metals with you can say other materials, which are mostly composites and ceramics. And the second aspect is that conservation of teeth beyond tooth is when the pulp is involved. And the endodontic problems are like so prevalent that the extraction is not the answer. The answer is to conserve and to treat. Without taking much time, and with the Dr. Mitra is a really and genuinely expert in the area, and we were very thoughtful when we chose her to be part of this series. And I'm sure today's presentation will be very interesting, and she'll like to fill up the everything in 1.5 hours in a very simplified manner. Over to you.
Thank you, sir. Thank you for your expert remarks. So now, without wasting much time, it's time to introduce today's speaker, Professor Mitra and Hegde ma'am. Ma'am is principal of A.B. Shetty Memorial Institute of Dental Sciences. Uh, Ma'am has, as sir mentioned, ma'am has 485 publications and a huge H index of 24. Ma'am has huge teaching experience of 35 years, guided and co-guided many postgraduate students and PhD students. Ma'am has many books, chapters in her name, and also 7 patents published. Ma'am also been awarded with numerous state, national, and international awards, including highest civilian award of Karnataka, Kannada Rajyotsav Award in the field of medicine. So the list is long. Just to save the time, I would like to make it short. So over to you, ma'am, and we all are eager to hear to you, ma'am.
Thank you so much, Dr. Jaswant, for that introduction. Respected Secretary Sir, Dr. Umesh Kapil, respected President, Dr. Digambar Bera, and respected Dr. M. Srinivas, and respected Sir, Dr. Karbanda Sir. Thank you very much for this opportunity. It is because of you that I am here presenting to all of them today. And it is indeed a privilege to be a speaker with the NAMS program. And I would like to, as Sir said, this is already helped me by giving a preamble telling that this is a topic which is quite a vast topic and there's lots to say, but I have put everything as a clinical presentation of the topics into what all is possible with this topic. So basically this presentation on restoration and rehabilitation of teeth with endodontics and restorative dentistry comes from A.B. Shetty Memorial Institute of Dental Sciences. This is an institute where I have been associated for the last 40 years and it comes under NITE University. So basically we are talking about the restoration and rehabilitation. So what would be the learning objectives? What are the topics that will be covered here? One will be the restorative techniques. And in the restorative techniques, we will talk about the direct techniques, which include composite and glass ionomer as restorative materials. Indirect restorative materials like zirconia, lithium disilicate, nano resin ceramic, and digital dentistry like CAD/CAM, CBCT, and intraoral scanners. And the second topic we will go to is endodontic therapy. And in endodontic therapy, we have the vital tooth therapy like the pulp capping and pulpotomy. And non-vital, we have the root canal treatment. So I would come to in detail of each slide. I'm just going to telling you what is a flow chart. And then we'll go to rehabilitation of endodontically treated teeth, which would be post and core and crowns. And the crowns these days, as Sir said, is changing. The material is changing. Dr. Karmanda Sir already gave an introduction as how the digitalization has come into dentistry. And surgical endodontics, what are the indications and what are the procedures? And we have the aids in dentistry, the aids in restorative dentistry, that is a microscope, CAD/CAM, and lasers. And then we talk about the aesthetic dentistry, which is the most interesting part of restorative dentistry, that is veneers, diastema closure, smile designing, and gummy smile corrections. So this would be the details of my presentation in the next 1 hour. So basically we start from why do we need to rehabilitate the teeth? And when we have to rehabilitate the teeth, we have to understand the teeth consists of the most important, that is the enamel. The enamel is the one which is white in color and which is the hardest substance. It is much harder than the bone and it is the most mineralized structure of our body and which is very important to preserve it. And once it is lost, then it is lost forever. It does not grow. So the next layer, it is a dentine that we talk about, which is a sensitive part of the tooth. So once it is exposed, then we come to know there is some sensation or we come to know that there is a cavity. So enamel caries is a caries which until and unless you go in for a checkup to a dental professional, you would not know that you would be having caries. And the third is the pulp. The pulp is a neurovascular system of the tooth. And the last is the cementum. The cementum is around the root surface of the tooth. And any caries at the cervical third involves a cementum, and it is a little challenging to manage. So these are the structures, the basic structures of the teeth, that is enamel, dentine, pulp, and cementum. So coming to the next step is, so the clinical spectrum is the early caries, moderate, advanced, and late. Depending upon the clinical spectrum, we have classified as. So early initial stages is whenever there is caries, the first thing that happens is demineralization. That is, a demineralization of the teeth occurs, and it appears as white spot lesions. These are the white spot lesions that appear on the tooth, and that can be simply treated by fluoride applications or ACP, CCP tooth paste, which can be topically applied, and it can be remineralized, or we can use laser remineralization. And in the next stage, we get small cavities on the enamel, but it will not be sensitive, so the patient may not be aware of it. This is called as initial carious lesion. So this could be diagnosed by a dentist. A little more deeper, when it goes into the dentine, the patient will have sensitivity to sweet or cold, or with slight shooting sensation for a short period of time. A conservative restoration can be done. And if it lingers for a little longer period of time, then we know that the cavity has gone deeper, it has gone close to the nerve. Then we need to do what is called as deep caries management. So it could be pulp capping, direct or indirect. But once it is already involved the nerve, the caries has involved the nerve, and the infection spread towards the periapical area, then you start getting spontaneous pain, and most often the pain continues at night, increases while lying down, and that is a definitive indication for root canal treatment. So these are the major treatment that we do in restorative dentistry and endodontics. So we used to classify these restorations depending on the surface that is involved as a single surface class 1 and two surface as class 2, and the anterior teeth, the two surface as class 3, and the load bearing area in the anterior teeth as class 4, and the cervical third area of anterior and posterior teeth as class 5, and the load bearing area on the occlusal surface, it is as class 6 restoration, and this is for a convenience of learning and recording purpose. So basically the caries is divided into enamel, dentinal caries, and depending upon the type of restorative materials changes. And if it is deep caries, then we do vital pulp therapy, or we might go for a root canal treatment. And after root canal treatment, we need to go for a crown, or it could be an endo crown, or if it is more than 50% of tooth loss is there, then we go ahead with what is called as post and core. So in restoration, most important thing that we have to do is remove only what is diseased, preserve every micron of healthy tooth structure, and to choose the most conservative option for restorative treatment. So most conservative option of restorative treatment is required. The reason is because we know that we have the best of the materials, but we also know that the enamel, the natural enamel, is the best of the material for the tooth. So this is a simple restoration where we remove the caries and go in for a glass ionomer base and a composite restoration. And in this case, you see it is a class 5 caries and it is rampant caries. So it is a simple glass ionomer restorations which are done. In glass ionomer restorations, where different types of glass ionomers are there, modified glass ionomers. And in glass ionomers, the advantage is it is an adhesion type of restoration, whereas in composites, it's a chemical and interlocking type of bonding which occurs. So depending upon the case, we need to select whether you're going in for a glass ionomer when the caries incidence is high, or we can go for composite when the priority is aesthetics. Coming to indirect restorations, we have different types of indirect restorations, that is inlay, onlay, veneers, and then we have the crowns. So the inlay is when the restoration is within the tooth structure, we call it as inlay, and onlay, it is the restoration extends onto the load bearing area, then it becomes an onlay. And a veneer is on the labial surface of the tooth, where thin layer is applied onto the surface, which we call it as a veneer, and a crown which covers the entire coronal part of the tooth and reinforces the tooth. Earlier, if you had to go in for an indirect restoration, it would be a second appointment or multiple appointments because we had to send the model to the lab and get back the veneer or the crown inlay or onlay. But with the concept of CAD-CAM, that is computer-assisted designing and computer-assisted machining, it is a single visit and a treatment where you can get the preparation done, you can do the scanning, and then we can deliver the crowns or the inlays or the veneers on the same day. So this is the advantage of the recent digital dentistry. And in this digital dentistry, we have the materials like zirconia, lithium disilicate, and now we have a new material called cryos, which is a submicron hybrid composite with CAD-CAM fabrication process, offering reliable, aesthetic, and fast restoration without separate firing process. So this, depending upon the material, from 20 minutes to 1 hour, we can deliver the restoration compared to the direct, which would hardly take about half an hour's time. So what is the modern restorative dentistry, digital dentistry? Earlier, we used to mix the material, have an impression, and then we have to pour the impression, which would take not less than 20 minutes to half an hour's time. But we can do that in 2 or 3 minutes with digital dentistry, where we scan the images and immediately we get the digital file ready, which you can either export to the lab or we can send it to our milling machine. So what is CAD-CAM? CAD is a digital designing stage in which the dental restoration is virtually planned and shaped on a computer, and it has data acquisition, virtual model generation, restoration designing, and software-based corrections can be done. Whereas CAM is a manufacturing unit where the digitally designed restoration is physically fabricated using automated machines. So this mills out the restoration for us, and it gives us a precise restoration which you can fit into the patient's mouth. So basically, we do the scanning with the scanner, and then the CAD designing also can be done with the software. We send it into the we mail it, which comes into the CAM, that is a computer-aided machining. So the milling is done. And if it is zirconia or feldspathic ceramic, then we go in for a speed firing. And once the speed firing is done, we cool it down and then we do the fit into the patient's mouth. So this digital dentistry has rapidly changed the era of restorative dentistry and becomes more convenient for the doctor. And most important, it is very precise and perfect. So what is a shift? Operator-dependent craftsmanship to industrially standardized biomaterials, artificial intelligence, and robotics are in play. This shift has increased the standards and the outcome of treatment across the clinicians. So the advantages compared to the conventional restorations or manually operated ceramics to CAD-CAM is it is industrially manufactured, it is microstructurally controlled, designed specifically for subtractive and additional digital workflow. So the precision and perfection is what makes a difference with CAD-CAM restorative dentistry. So if you see this picture where the scanning is done, when we do the scanning, as the patient enters to the clinic, we do the scanning, and on the scan, we can explain to the patient the treatment plan. We can show the patient the pre and post, and we can go ahead with the restoration required. So the advantage of CAD-CAM is speed, ease of use, and accuracy with our restorative techniques. So this is a case where you see a patient came with a mandibular anterior teeth which is fractured. So root canal, so we can do a root canal and then we can do a coronal buildup on the same day. Root canal treatment was done, and you can see pre-operative tooth was like this, and you build it up with the post and core, and then you do the scan. The scan restoration is designed, and the restoration is proposed by the software. It is done by the milling machine, fitted, try-in is checked, and then staining and glazing is done and fitted in. This can all be done within 45 minutes to 1 hour for a patient. So which is to take about a week or so, which has to go back to the lab and come back. And the number of hours in the clinic and the number of hours in the lab has been reduced to less than 1 hour. And that is the advantage of modern dentistry. So what are the different materials that are available for use in CAD-CAM? So it starts from the strength, the requirement of the strength as a temporary material we can use for as 150 MPa to the best of the materials of 1000 MPa is required. So the material selection depends upon the case, the type of patient, the masticatory load of the patient, and that is how we have the different materials available in the market, like the feldspathic, the composite, the lucide reinforced composite, inorganic resin, lithium disilicate, then we have the zirconia with lithium disilicate, like the tessera, and then we have the zirconia. So these are the different materials available in the market, which we need to do case wise. So the next most important type of caries that we normally see, which normally we see, is the radiation caries. I thought I should add this because this is a common problem that I had seen in my clinical practice, that is radiation caries. Earlier, we used to find radiation caries in only when patients undergoing head and neck cancer. But now we see radiation caries with patients undergoing radiation, even for prostate cancer. We find that there is radiation caries. Radiation caries is a tooth decay that occurs as a side effect of radiotherapy and mostly because of the lack of the salivation. So whenever the salivation is decreased, the oral defense mechanism is decreased, and there is the microorganisms attack the cervical third of the tooth because of the failure at the cemento-enamel junction at the cervical third, and this most often occurs because of the irradiation of the tooth. So restoration of the radiation caries is very important. Restoration, because most of the patients undergoing radiation would not come to our treatment for the next 6 months to 1 year until until their radiation therapy is over, and most of the time they come off with this would be a pre-operative of a patient whom you would have seen 6 months earlier before the healthy, and this is after they undergo the radiotherapy, they come back with no smile or the lost smile. So this is a very important part. This is one of my patients who had a radiotherapy and a chemotherapy and post-operatively, where we did a full mouth rehabilitation. So most important is these cases, they will be physically weak, mentally weak, and if they lose their smile, they will lose the hope of having communication with the public. So restoring a smile for a radiotherapy patient is most important and becomes a very crucial part of restorative dentistry. So the next challenging thing that I have seen is root caries. Root caries is preventable. It is one of the debilitating dental disease and has been identified the main cause of dental pain. And here it occurs most commonly whenever there is a periodontitis and there is a gingival recession and the exposure of cementum, there is root caries. Most commonly, root caries is seen in patients where there is an oral defense mechanism as nil or reduced. This occurs whenever the patient is under long-term medications or long-term antibiotic usage. So they would have undergone some discomfort in the gut, and that is why the gut flora and the oral flora changes, leading to decrease in the resistance and leading to root caries. So this is another challenging case where we found the prevalence of root caries in India is quite high, which could earlier I used to see out of, at an age of 65, but now we find root caries even in a patient of 35, and this could be associated with the changing lifestyle. So we did a prevalence study and found that 3 out of 10 persons in India may be affected with root caries, which is a serious health issue. So for all dentistry to be perfect, we used to need to some aids. That is, one is microdentistry. The use of microscopes is a need or a need of the hour or a must for anything, whether it is a endodontics or restorative dentistry or microsurgery, because when you can see something better, you can do the best. And this is how we achieve perfection and precision. CBCT is another aid that we use for everyday diagnosis and treatment planning. CBCT helps us in extremely good documentation because the machine that I use, that is a PlanMica ProFace, it gives us the muscle, the facial profile, the muscle profile, the bone profile, and there is nothing which is transparent. We can check it layer by layer. So we have the CBCT, which helps us in exactly mapping the anatomy, planning our treatment, and we can overlap the pre-operative and the post-operative images, and they're extremely good for diagnosis, treatment planning, and documentation. The other important aids that we commonly use in dentistry is the loops. This is a loops, the prismatic loops with light is what I commonly use whenever there is some areas which is not accessible to my microscope. And the second most important aid which we commonly use is the diode laser. The diode lasers are used either for endodontics or restorative dentistry or caries prevention or bleaching or pain management. So the laser has become another advanced tool which we use in everyday practice. Coming to the next topic, after restorative dentistry, we move on to endodontic therapy. Endodontics is basically about the root canal system. The root canal system is a nervous system within the tooth which has a complex anatomy, which is it is not a simple anatomy, it is complex, and it has got multiple curvatures and accessories and lateral canals, deltas and isthmus. So this is quite complicated. So we have to preserve the nerve, or we need to treat the nerve by removing and cleaning it. So what is endodontic therapy? The rationale of endodontic therapy is based on the belief that a natural tooth functions more efficiently and comfortably than a bridge, partial denture, or a metal implant. And the objective of endodontic therapy is restoration of the treated tooth to its proper form and function in the masticatory apparatus in a healthy state. So the first thing that we know about enamel, dentine, and pulp. So any cavity which is very close to the pulp, then we do an indirect pulp capping, where we have a minute amount of dentine which acts as a bridge in between the caries and the pulp. So if we have a bridge in between, then we use the material which is either mineral trioxide aggregate or biodentine or bioceramic sealers. We apply that, and above that we put the glass ionomer cement, and then we use the composite to seal it. Whereas if in case the caries earlier extends up to the pulp, earlier we used to go directly for root canal treatment. But now in cases where we can use a disinfectant like the laser to disinfect that area, we disinfected that area with the laser, followed by use of MTA, that is mineral trioxide aggregate, glass ionomer cement, and composite. So this is called as indirect pulp capping when there is a dentine bridge, direct pulp capping when it goes directly onto the pulp, and pulpotomy procedures where we remove a small portion of the pulp out and then seal with MTA, glass ionomer, and composite. So what are these three materials? The mineral trioxide aggregate, biodentine, or bioceramic sealers. These are called as the biomimetic materials and the bioactive materials, which help in the formation of the bone-like or the cementum-like or the tooth-like cells which are formed. So in root canal treatment, starting from the disease, the most important is the diagnosis, whether you're going for pulp capping or whether you're going for a root canal. Eliminate the cause is the next step. Then we do in root canal treatment, we do the access cavity preparation, and then we do the instrumentation and disinfection and the root canal filling, and finally the access restoration, which leads to ends up in healing. So if you want to see the diagrammatic flowchart of root canal procedure, it is a common terminology that we use. We first have to block the nerve for it to be pain-free, and then we do an access cavity preparation to get an access to the nerve, and then we do cleaning and shaping of the root canals, and then we do a thorough irrigation. Cleaning and shaping was earlier done by only hand instruments. Now we do a combination of hand instruments for the tactile sensation, followed by rotary instruments for cleaning and shaping, which is quite efficient and faster. And then we use a lot of irrigants, different kinds of irrigants for flushing out the toxins. And then we clean, after the cleaning, shaping, and drying the root canal, we fill it with a special material called gattapercha and seal it three-dimensionally. The three-dimension is apical, lateral from the periodontal tissues, and occlusal. And then we do an access filling of the coronal cavity, followed by a crown to make it more stable and to make it resistant. So in cases where the root canal treatment fails, then we go in for, or if there is a cases where there is a problem with the root canal treatment, then we do undergo endodontic microsurgery. Earlier, it was called as endodontic surgery, but no surgery is done without microscope, and that is why now it is called as endodontic microsurgery. So could be a simple surgery like just removal at the apex, which is called as epicoectomy, or it could, and then root end preparation, and then using of the bioceramic material or mineral trioxide aggregate material. So this is one case where you see a non-vital tooth, the patient comes, we open the flap, we open the area where these cyst is, we do the root canal treatment, single sitting, and then we fill it. We do a root end filling, and the root end area is filled and the flap is placed back, and then you can see that this is how it is post-operatively in the radiograph. So this is a case wherever there is a failure of an endodontically treated teeth, and then the second time, if we go in for surgical endodontics, or if it is a huge cyst which needs to be enucleated, then we go in for a surgical endodontics. So this is another simple case report where you can see this is a fractured tooth, the tooth which had a huge cyst. So it was actually for an extraction, but this was extracted and we realized that it was a fractured tooth, and we did the root canal treatment outside the tooth. Retrograde filling is done outside the mouth, and the cyst is enucleated, and the tooth is repositioned back into position and seated into the socket, and you can see the post-operative radiograph. So such cases like this also can be done, but this is not the standard operating protocol. So we need to take a consent for the guarded prognosis for a patient when we do something other than standard operating protocols. So can we come to the next topic, that is a rehabilitation of an endodontically treated teeth. This is done when we have a very small tooth structure, that is most of the tooth structure is fractured, and there's a small tooth structure which is remaining, that is less than 50% of the tooth structure or the supporting dentin, then we need to have an additional retentive aid. So that is why we put a post inside the tooth, and this post could be fiber post or it could be a metal post, but the gold standard earlier was a cast post which is made out of the gold, which is called as a type 2 gold. So we used to use the 22 karat gold to make the post and core, and that was a standard earlier, but now we use fiber-based post, which is much faster because there is no lab work involved. In this fiber post, we just use the fiber post, we bond it onto the tooth inside, and then we go ahead with the core build-up and the crown. So this is how it is built up. So you can have we can see that step-by-step procedure for fiber-based post, prefabricated dowels and cores. So this is the fractured tooth. The post space is prepared. The root canal treatment has to be done, and then we have to do a post space preparation. We have a specific instruments for that, and trial fit of the post is done, and self adhesive is application of the adhesive is done, light curing is done, and the core build-up is done. And after the core build-up, and over that we put a crown. So the advantages, it's a single sitting and it's a monoblock effect. The same post core can be done with the metal, and the most preferred material is gold. But it would be a little more expensive because of the nobility of the gold. But commonly earlier we used to use only gold, but now we have the prefabricated post. So we have the glass fiber post, which we see here, versus this is a metallic post. And in the metal post, I told the most convenient or the most preferred material is gold. Coming to cast metal post and core, this is a patient where you can see there is the two teeth which are fractured at the cervical third, and this is root caries once again, and you can see the caries over here. And post-operative, you can do root canal for those two teeth, put post and core, and go ahead with the crown. So the advantage of post and core is we can bring back the smile of a patient on the same day when they come onto your chair with the root canal treatment and post and core. That is an advantage of the endodontics, where we can bring back the smile of the patient on the same day. Coming to the next most interesting topic, that is aesthetic dentistry. Aesthetic dentistry is something which everybody likes because there is nothing more attractive than a beautiful smile whether you are creating it or you are wearing it. So this is a smile that everybody wants to have. That is the best, and that is the best thing that to give you the confidence of what you can do. And in smile designing procedures, as restorative dentists, we can decide which smile they want. The patient can bring the smile and say, I want these smiles, and we can give them that particular smile. That is the advantage of restorative dentistry with the CAD CAM. We can give them the biocopy of the picture of what smile we want, and the AI designing helps us to give us the similar smile to the patient. So we have the smile designing software which helps us how to plan the smile and what to show the patient what type of smile he can have before and after. This is a simple case where we call it, there is a space in between the teeth that's called as a diastema, midline diastema. This is a case where there is a pre-operative and you can see post-operative, the diastema is closed. So this is another case where you can see a simple diastema and we have put two laminates, and you can see post-operative, the diastema is closed. That's a simple aesthetic design. Here you have multiple areas of diastema. So it's multiple areas where the 4 teeth are involved and the diastema is closed, pre-operative and post-operative. And you can see the workflow which is done, the preparation which is done, and then the laminates which are placed. So this is another case where you can see it is a pre-operative value addition of smile. This is simple value addition which was done by bonded composite because of the cost factor. But you see when we modify this 5 front teeth, in this case, the smile changed. And then most important, no smile designing, no aesthetic dentistry is possible without a healthy gingiva and occlusion. In this case, you can see there is a clasp here, that is, there was a cast partial denture given to the patient. So remember, aesthetic dentistry and restorative dentistry needs to be done on a strong foundation, that is a healthy gingiva, and most important, a good posterior occlusion. The occlusion should be perfect. If there is an imperfection in the occlusion, the aesthetic dentistry fails. So coming to value addition of smile, this is a lateral incisor where there is a lateral incisor which is a peg-shaped lateral. This was a school child who was in 7th standard who never used to smile, and I really feel good to see her after that with a crown laminate added on to her teeth. She started smiling, was what her parents used to always be very happy about. So these are small value additions which can occur with laminates and veneers. So this is a rehabilitation with simple composite material. We can build up the entire teeth and then we can change the smile of the patient. So this is a missing lateral incisor. So the canine is converted into a lateral incisor and the 2 central incisors are built up, and the premolar is converted into a lateral incisor, and aesthetically it is modified. So no addition of teeth was done. So this was done with composites with a minimum cost. So all the treatment plan depends upon the type of material, the type of patient, and the cost involved in the treatment. So this is another case where you see there is a peg-shaped lateral teeth which is converted into a complete lateral incisor by the use of veneer, and then you see there is a bleaching which has been done for the patient. So there is a change in the smile. So this is another patient where you see it is multiple. This is a case where you can see there is multiple restorations and worn out teeth, which were all treated with a beautiful laminate veneers. And this is a patient whom I see even after 15 years, the laminates, much more than 15 years now, that the laminates are intact. And this is what makes wonders for aesthetic dentistry and the materials in aesthetic dentistry, where we just apply a layer of ceramic laminate, which is bonded onto the tooth. This was a patient, one of my patients who wanted to, this is quite common that we have, as just before their marriage, they want to change the smile or they want to increase the value of their smile. So this was a pre-operative picture. If you see, we underwent a root canal treatment for the central and lateral restorations, and then the crowns were put from canine to canine. And as we put the crowns from canine to canine, we change the smile of the patient. So we can change the position of the tooth, we can change the smile line, and we can change the occlusion with the veneers, laminates, and crowns. And this is called as smile designing. And when the length of the tooth, when the position of the tooth was brought down, you can see that the length of the tooth appeared to be big. So that is why we added on pink ceramic in this case. This is another patient where there was a large diastema and could not afford for a non-ceramic crown. So we had to go in for a metal ceramic crown. So this is a post-op, pre-operative and a post-operative. Even though it is not as good as a non-ceramic crown, but it would be, it would definitely help her to smile with confidence. So this is another case where you can see actually the preoperative smile did not have much of a problem except for the worn out cervical thirds and slight if you see, this is a reverse smile. It is not the smiley smile, it is a reverse smile. The only thing that we did was modification of the smile line, but when there is very little modification to be done, not much of errors, it is a very critical treatment planning and very difficult to analyze. So we go to the next topic, that is the gummy smile correction. In gummy smile correction, this is a patient who had a gummy smile pre-operative, and you can see the gummy smile post-operative. So in this gummy smile correction, we also realize that since we use the lasers, the pigmentation also goes off with the lasers. This was a case where we use the laser for the gingivoplasty, that is a gummy smile correction. So whenever we have a gummy smile, the first thing that we do is we put the marking spot, bleeding points. There's a patient where there's a gummy smile, we put the bleeding points. So we know where we have to cut, and then we put the bleeding points with the laser, followed by which we cut with the laser and remove that length of the gums. So when we remove that length of the gums, the length of the tooth increases, and the amount of tooth exposed increases, and the amount of gum exposed while smiling decreases. But with this treatment, I think this was done in 2014, and I see the patients even now. With this treatment, we realized that use of lasers also depigmented the teeth. The depigmentation occurred, and the depigmentation was permanent. So this was also another learning process for us during the use of lasers, that it could be used for depigmentation, and after which I think it is rapidly used for depigmentation. So there's another case where there is a gummy smile after orthodontic treatment, and gummy smile correction was done and veneers were applied because the tooth were hypoplastic and it was a lot of caries. So we had to do going for veneers. So this is a gummy smile correction followed by veneers. So this is the case where we initially did the gummy smile correction, and then we put the IPS Emax laminates and veneers because there was hardly any enamel on the tooth surface. It was dentine which was exposed and it was yellow in color. And so we added on the veneers to increase the value. It was a no preparation veneer, so there was no preparation at all. So it was just the gummy smile correction and increasing the length of the tooth, followed by the no preparation veneers which were bonded onto the surface of the tooth. So lasers are quite often used in dentistry as a tool in dentistry. And the advantage of laser, it can be used in low-level laser therapy for biostimulation, and it could be used for diagnostics caries or caries prevention. It is used for caries removal, that is a hard tissue lasers. In endodontics, we use it for disinfection of the root canal, and it is also used for drainage of abscess, and it is used for pain management. So there is multiple uses of lasers in dentistry, which is a part of our everyday use. So in prevention of caries, we use the 3.5 to 4 watts for remineralization of the tooth. And for etching, we use the lasers. And for remineralization of the tooth, we use lasers. We apply the lasers, which increases the potential for remineralizing agents of ACP, CCP. We also use the lasers in caries removal and for cavity preparation, and in the cavity preparation phase, and most often we use it in case of pulp capping, where we do direct pulp capping, disinfection of the tooth, and then the restoration of the tooth. So if that cavity has gone up to the nerve, what we do is we excavate all the caries, disinfect that area, and then you put a biomimetic material and then restore the tooth. And this is a common thing that we use in everyday practice for in cases where we think that the infection has not gone directly entire into the pulp, we use this laser disinfection. So we also have the laser assisted root canal disinfection. So when we are doing the routine root canal treatment, we use a laser filament right down up to the apical third, and we do the disinfection. And with laser disinfection, it is feasible to do a root canal treatment in a single sitting. So when we have the equipments like lasers, the rotary systems, and we have the CAD/CAM, CBCT, it is a benefit for the patient and the doctor because it saves a lot of time and energy. So this is a case where it was a patient, it would be routinely this patient who had a large periapical lesion involving two lower anterior teeth would have to have about to come regular conventional treatment would have to come about 5 to 10 times for the treatment. But in this case, it was root canal retreatment was done in a single sitting, followed by laser disinfection, and then the periapical area was also done. Laser curettage was done for the cyst enucleation. Cyst was enucleated, and the laser disinfection was done, and the patient was sent with all the treatment done in a single day. So this is the advantage of lasers. This is the advantage of lasers in dentistry and use of the advanced techniques in dentistry. Laser is also used when we have an abscess, and when we use the laser, instead of using the incision and drainage, we use the lasers. So coming to the different aspects of restorative dentistry, I've completed the restorative dentistry, direct restorations, indirect restorations. We have gone to post and core. We have gone to endodontics. We have used of digital dentistry, lasers, CAD/CAM, and CBCT. So thank you for a patient hearing.
Pictures, and that presentation was very engaging for all the listeners. So before I read out the questions which are asked in the chat box, ma'am, I have one doubt and I'll ask it.
Yes, sir.
That our crowns are mandatory for all the post RCT tooth, or it may be avoided, or if it is mandatory, so what is the ideal time ki after that procedure completion, after how many days or months we need to get it done? Ji ma'am.
It's a very good question. I think you have asked just once. This is a question like most of the patients have. And in fact, that is the need of the hour. See, root canal treatment is done. Depending upon the amount of tooth structure remaining, because if there is lot of caries, there is lot of tooth structure destroyed, then the resistance form of the tooth comes down. So we do the root canal and we do the filling. But what happens is most of the time there's only an eggshell, just like an eggshell, the tooth will be there and the entire thing inside is a restoration. So in such a situation, if we do a root canal and after about a week's time, we tell them not to eat on that side for 1 or 2 weeks. That is because the periapical area is a tissue which heals. The pain comes down in 1 week and in 2 weeks, it's all fine. And in 2 weeks, if you go to bite something very hard, the tooth just can chip off because it's only the eggshell of the tooth which is remaining. So the deciding factor whether we need to go for a crown or we go for an endo crown or we go for a restoration depends upon the amount of tooth structure which remains. Most of the time, if it's a grossly decayed tooth, we advise for a full crown. Now we have an alternative where we do an endo crown. Like if it is a hollow tooth, the whole hollow tooth, we take an image of that with the scanner and then we make an endo crown. So instead of putting a restoration, we bond the endo crown onto it. So these are the two options. But how long was the next question that you asked? We can do the crown on the same day because now because of the CAD/CAM and CBCT, we can do it on the same day or we can do it much at the earliest or we can just go ahead reduce it from occlusion and postpone it in case you do not have time.
Right. Thank you, ma'am, for the most clarified way of answering this question, ma'am. This clears all our doubts. So now again, I would like to remind the participants and the listeners to post your questions in the chat box. So I'll read out the questions, ma'am, for you.
Sir.
Dr. Mahesh asked on YouTube regarding endocrines. So he asked, endocrines are suitable for premolars or only molars? Also, which material is better, lithium disilicate or zirconia composites for the, I think, endocrines?
Yes, we do not use zirconia for endocrines. We use only lithium disilicate, or we could use a resin based crowns like cryos or any other material, because these days, because that we can require something softer and little milder form of materials. And endocrines can be done even for a premolar, it could be done even for a molar.
Right, ma'am. Right, ma'am. Thank you, ma'am. And how do we decide the extent of pulp to be removed in pulpotomy?
Okay, that is also a very good question. Because in case when we do the caries excavation, once we do a caries excavation and we see some amount of bleeding, it stops after some time. So the caries excavation, we can depend upon the, whenever we use lasers, we do not do much of an excavation of caries. When we use lasers, that is what we use often these days, we do not do any excavation, we do a laser disinfection, because many microorganisms is killed by it, and then that area gets disinfected. So there is no excavation as such which we choose to do earlier in pulpotomy procedures. So we just do the laser disinfection and then we use the biomimetic material over that and then go ahead with the restorations.
Right. Thank you, ma'am. Thank you very much. I would again request the participants to write questions, or they may just, if they are hesitant to type or they are lazy to type, they can just raise their hand and we can unmute them. Yeah, Dr. Kumar Anand is with us. Dr. Kumar Anand, you can just unmute and you can ask the question.
Very good afternoon to all, sir.
Good afternoon.
Yeah, please.
Ma'am, good afternoon. Ma'am, my question to you is regarding in relation to orthodontics also, that suppose if a tooth is treated in a root has been done a root canal treatment and needs an orthodontic treatment, the patient also needs an orthodontic treatment too at the same time. So what are the precautions and what are the things that needs to be kept in mind?
Correct. Yeah. Once we do an endodontic treatment, that is a root canal treatment, as we know, any tissue takes about 1 week for the inflammations to come down, and total inflammation to set down takes about 2 weeks time. So we always have to wait for that time before we load. But in case there is a root canal treatment done for a tooth with a lot of bone loss, or if there is a periapical bone loss, the tooth is held within the bone. So the bone is the one which supports it. So if it's a healthy tooth, after 2 weeks of root canal treatment, there's absolutely no problem. But if there is a bone loss, cervical bone loss or apical bone loss, and the amount of bone loss is more, if there is a lesion apically or cervically, then we say we need to leave it for at least 1 month's time, that is 4 weeks, for it to regain back to normal. So depends upon from case to case, depending upon the bone loss and the position of the tooth. These are the two important things that we look in for.
Ma'am, one more question, ma'am.
Yes.
Ma'am, if a retraction has to be done orthodontically, suppose an NMAS retraction has to be done or a single canine retraction has to be done, that has been treated with a root canal treatment, ma'am. What are is there any side effect in during retraction, ma'am? Because the tooth has now become non-vital. Is there any sort of things that needs to be kept in mind during the retraction in of an RCT treated tooth, ma'am?
Now, what I would say is before you go in for an orthodontic treatment, get an CBCT of that tooth done. Because if the root canal treatment is done perfectly, there's absolutely no contraindication after 4 weeks if the tooth is fine. And 2 weeks if there is absolutely bone loss. But in case if there is any error, endoperio leakage anywhere, then you will start getting resorption of root. So it is always best to have a documentation of a CBCT and then go on with the orthodontic treatment.
Okay, ma'am. Ma'am, one more question, ma'am. Ma'am, as you have discussed some cases regarding diastema closure, and so why is it that the conservative management is done if we have the orthodontic management, ma'am?
It's a very good question you're asking. So it all depends upon the needs of the patient. See, the patient, most of the patients do come where they want it. Why do they come to a restorative dentist? When they want something within 1 day or 1 week or 1 month. And they would have been there with the problem with them for years. And they know that if there's an orthodontic treatment, it is 6 months or 1 year. So they only when they want it as an instant relief, then they come to a restorative dentist. And when they come to a restorative dentist, these are the options. We do give an option of orthodontic treatment also. And then these are instant solutions, that's all. Otherwise, I think that the two cases which I presented, both the cases were instant solutions.
Ma'am, but as the department name suggests, conservative.
Yes.
So why, if any veneer is being placed, some amount of tooth reduction has to be done.
No. Veneers don't require tooth reduction until and unless it is labally placed and you want to change the position. Otherwise, no preparation veneers are there. We want to bond it onto the enamel. And when we bond it onto the enamel, the veneer life is long. So most of the veneer preparation is almost no preparation. Only when that you want to modify the tooth structure, like in case, one case that I have shown where you want to actually move the tooth slightly 1 millimeter lingual. So in that case, we go in for a lot of preparation to be done. Otherwise, it is a no preparation in most of the cases.
मैम इन मतलब ये बात ये हुई कि एक नॉर्मल टूथ है, इट इज
Dr.
सपोज अ
Anand,
पेशेंट हैज कम टू अ नॉर्मल टूथ and ma'am he has for diastema closure ma'am, and ma'am आपका वो फोटो नहीं दिख रहा मैम, if I'm okay with it.
Yeah, that is one of my, that one case is the only case which I put is of my PGs. All other cases are mine.
No,
That
ma'am. I'm
diastema,
asking,
yeah.
ma'am, just I'm asking all these things
Yes.
for my
See,
knowledge. I'm
yeah,
not.
correct. See, there are a few patients who want it. There are a few patients who want it, and you give an option of composite, you give an option of laminates, you give an option of different materials, and we need to give the patient the options. Then you take the consent and you do it. So basically, when you give composite, we have a lot of restrictions that you put. But when it is a bonded material, we have less amount of restrictions. So the patients prefer veneers. But the advantage with veneers is with the composite, there is a possibility of staining. There is a possibility that they need to come back every 6 months for polishing. Sometimes a few patients with maybe 1 year, but a few patients, if they're using lipstick, then there is a problem. But with ceramic, we do not have those problems.
Okay, thank you.
Thank
Ma'am,
you, Dr. Anand.
sir, I would like to
Uh,
ask some question from Karvanda, sir.
Sir is currently, I think, is busy, but we need to allow other participants
one thing,
to
just one
utilize
thing, sir.
their opportunity, their
Okay,
queries.
okay, sir. No,
Yeah.
fine, sir. Sir, just
Sure.
one thing I would like to put up to the administration, sir. The regarding information about the NAMSCON webinar. Earlier, I used to get the email on the same day also. That was जैसे आज है sir. तो आज सुबह भी एक email आया करता था. But from the last seminar, last time भी नहीं आया, तो वो मैंने मिस कर दिया. बट आज जो कि मैंने मतलब थोड़ा याद रखा था, तो जस्ट आई वांट टू पुट अप दिस मैटर कि सर एक रिमाइंडर ईमेल अगर सेम डे आ जाए तो इट विल बी
Right.
गुड फॉर अस सर.
Sure. Thank you.
Thank you sir.
Sure. Thank you.
Thank you ma'am, thank you for the answers ma'am.
So,
Thank you.
ma'am, there are other queries which are posted. So, in root caries restoration, considering the challenges of bonding to sclerotic dentine and moisture
Yes.
control, would we still prefer RMGIC over composite in subgingival lesions?
Yeah. I would say to prevent, initially we have to go in for prevention of caries. So initially we go in for glass ionomer bonding, which is adhesive dentistry, because bonding becomes a challenge there with the cementum. We go in with the glass ionomer. We have some good materials in glass ionomer, gold quality materials. So we go ahead with the glass ionomer. and then it becomes an interim restorative material. And then after a period of time, when the patient caries control occurs, which is normally 3 months to 6 months, after that you go ahead with the laminates of composite or ceramic.
Right. Thank you, ma'am. Another question is that in pulpotomy, will replacement of MT,
MTA.
MTA,
Yes, sir. Yes, sir.
followed by permanent restoration be done on the same seating or separate seatings?
When we are doing pulp capping, we place MTA and we go ahead with the permanent restoration on the same setting. Earlier, we used to give a temporary and then recall the patient with a permanent. But now, since we are using equipment like the laser for disinfection, then we are using the MTA, and then we are having good quality of materials, glass enamelers as base and composite as final restorations. We do it as a single setting.
Right, ma'am. Another doubt regarding pulpotomy, ma'am, that in case of atresion and vital tooth with less RDT, if we plan for overlays, how to manage the occlusion? Do we need to do pulpotomy to prevent the future pain?
No, when you plan for overlay, we need to plan for the thickness of the restoration and what is the restorative material you are going to choose. So if it depends upon the patient, so the material of choice varies depending upon the, it could be a ceramic, which is onlays, and depending upon the bite of the occlusal bite of the patient. So build of the patient determines the occlusal bite. A patient with a huge masseter and a pterygoid muscle will always have a better occlusal bite. So in such cases, we need to go for materials like zirconia, which is much harder. Or we need to go in for material like cryos, which is much flexible. So that in every case, depending upon the occlusion, depending upon the priority, and depending upon the thickness, because zirconia, the thickness is much lesser. And if you want to go for lithium disilicate, we need to have more thickness. So depending upon the amount of their thickness which is available for us, the selection of material is done. And we don't do pulpotomy procedures in order to go for onlays or overlays. We need to do an analysis. Prior to that, we need to take a radiograph, check the pulp horns, the height of the pulp horns, before going or planning for an onlay or an overlay.
Thank you, ma'am.
Yes.
So I think these were the queries which were posted in the chat box, and questions were asked by Dr. Kumar Anand. So if there are still any questions, one can unmute themselves or they can just raise their hand.
I think Dr. Parul Garg has a question.
Dr. Parul Garg, you can unmute yourself.
Good morning, ma'am, and good morning, sir. So I have a question. That how should a case of failed RCT presenting with an axis be cured or be treated in percussion area?
Can I get the question once again?
Can you please repeat, Dr. Parul?
Yes, ma'am. Ma'am, when we do RCT and after a certain time period, the RCT is failed and axis is formed in the percussion area, then what will be the treatment option in that case?
So the question was, if there is a failure of the RCT, what has to be done? Am I right? Yes. So if there is a failure of RCT, we need to know, first we need to analyze where the failure has occurred, whether it's an incomplete filling or an over-obturation or a missed canal. So we need to find out what the problem is, and there is something called retreatment. We do the retreatment and we analyze what is wrong and we correct it. And that is called as retreatment endodontics. So that can be done. Retreatment endodontics can be done. Have I answered your question, Parul?
Yes, ma'am. Ma'am, in case if any canal is missed, then what should be done? Should we repeat or hold the RCT procedure again, or should we treat the missed canal?
If the other canals are filled perfectly and they have no problem, you need not redo it. So only the missed canals needs to be clean shaped and it needs to be restored. So yeah, normally we do the entire procedure because whenever we have missed a canal, that means there is some error which has occurred. So we normally go in for an entire treatment. Missed canal is very rare, but if it has occurred, we need to do the retreatment and rectify it and restore it.
Okay, ma'am. Thank you so much.
Thank you for the question and thank you, ma'am. I think if there are no more questions, we can proceed further for the vote of thanks. I'm not able to see any raised hand now. Okay. So, fine. So now I would like to request Professor Umesh Kapil sir for the word of thanks.
It's a proud privilege. It's a proud privilege to give vote of thanks. My most sincere thanks to Professor Hegde for delivering a very interesting and informative presentation. People have, these participants have listened to your presentation very carefully. They raise queries which they have, and I'm sure that the participant would like to learn more from you. And I suggest that if you have missed, if the participants have missed out something, they can go to the NAMS website where the PowerPoint presentation as well as the online presentation is available. My sincere thanks to all the participants who have spared their time and participated in this scientific session. Thanks to all our backend team members and Dr. Jaswant for coordinating the session. And with these few words, once again, thank you very much to all of you, including Professor Hegde. Thanks a lot.
Thank you, sir. Special thanks to NAMS and thank you, sir, for giving me this opportunity. And it was my pleasure sharing my knowledge.
Thank you, ma'am. It was an excellent lecture, ma'am, and we all could listen to it. Like there was a variety of listeners among the participants. Like there were medical students, there were dental students, there were dental professionals, and medical professionals. So we all could learn a lot. Thank you very much, ma'am.
Thank you.
So with permission of sir, we can mark the closer.
We can close the session.
Right, sir. Thank you, sir.